Let's start diagnosis and management of gestational trophoblastic disease, Figo 2021 update. The gestational trophoblastic disease arises from abnormal placenta is composed of spectrum of pre-malignant to malignant disorder. The change in epidemiology of GTD have been noted in various countries. In addition to histology, molecular genetic study can help in diagnostic pathway. The earlier detection of molar pregnancy by ultrasound has resulted in changes in the clinical presentation, decreased morbidity from uterine evacuation. Follow-up with human chorionic gonadotropin is essential for early diagnosis gestational trophoblastic neoplasia. The duration of HCG monitoring varies depending on the histological type and regression rate. Low risk GTN, Figo stage 1 to 3, score is less than 7, is treated with single agent chemotherapy but may require additional agent. Although score 5 to 6 is associated with more drug resistance, overall survival approach is 100%. High risk GTN, Figo stage 2 to 3, score more than 7 and stage 4. Is treated with multi-agent chemotherapy with or without adjuvant surgery for excision of resistant foci of disease or radiotherapy for brain metastasis, achieving survival approximately 90%. 2 to 3, score more than 7 and stage 4. Gentle induction chemotherapy helps reduce early death in patients with extensive tumor burden, but late mortality still occur recurrent treatments resistant tumor. The gestational trophoblastic introduction. The gestational trophoblastic is a group of uncommon conditions associated with pregnancy. Histologically, it includes the pre-malignant partial hydatidiform mole, complete hydatidiform mole, as well as malignant invasive mole, choriocarcinoma, site trophoblastic tumor, and epithelial trophoblastic tumor. The last three malignant forms can arise after any type of pregnancy. All are collectively known as gestational trophoblastic neoplasia. The GTD spectrum has recently been expanded to also include atypical placental site nodules, as 10 to 15% may coexist with develop into placental site trophoblastic tumor or epithelioid trophoblastic tumor, while PSTT and epithelial trophoblastic tumor and APSN, that is atypical placental site nodule, have more varied production of the pregnancy hormone, human chorionic. All other forms of GTD produce this hormone. Indeed, HCG is an excellent biomarker disease progression response subsequent post-treatment surveillance. Thus, plateau or rising HCG level enable the early detection of progression of complete hydatid mole or partial hydatid mole to GTN that occurs in 15 to 20% and 0.5 to 5% in partial mole respectively. Use of this biomarker together with the development of highly effective therapy has transformed the survival outcome so that today nearly all women affected by GTN can expect to be cured if managed properly. Wide variation in epidemiology exists in the reported incidence GTD with high frequency reported ASIA, Middle East, which may influence by the difficulty in obtaining accurate data. The incidence of hydatid form varies 0.57 to 2%. Recent report the Republic Korea, Japan show that the incidence of hydatid form mole has become as low as that of Europe or USA. The established risk factor complete mole pregnancy at extreme of maternal age and primary pregnancy compared to the risk for the 21 to 35 years age group, risk of complete mole nearly twice for women younger than 21 years, older than 35 years. 7.5 times higher for women over 40 years age. This suggests increased risk of abnormal gametogenesis and population of the ovum produced at extreme reproductive age. The prior molar pregnancy increased the risk 10 times sporadic complete moles, while familial clustering and recurrent mole is the rule in familial biparent recurrent moles due to mutation in the NLRP7 and KSDC3L gene. KSDC3L. The reported incidence choriocarcinoma is range 1 in 40,000 pregnancy in North America and Europe, 9.2 3.3 pregnancy. The complete hydra consists of hydropic villi, semi-transparent vesicle, variable size with absence of normal placenta. Earlier complete hydatid mole may have minimal, no gross evidence of abnormal villi. Differential diagnosis of complete include partial hydropic abortion, early normal gestation with fibroid trophoblastic hyperplasia, histologically complete moles of fluorid cistern formation, trophoblastic proliferation, absence of fetal parts, significant cytological atypia, mitotic figure may be seen in the first trimester. Complete hydatid mole may not be markedly enlarged but have distinct polypoidal appearance with abnormal villus stromal changes and mild to moderate trophoblastic hyperplasia. In contrast to such histological feature are less marked in partial mole, fetal parts are still absent, fetal present. Hydropic spontaneous abortion may mimic the appearance of partial mole. A cyclic dependent kinase inhibitor P57 encoded by the paternally imprinted maternally expressed gene hence is absent in the villus cytotropin It is paternally inherited but maternally expressed gene. Hence, its absence in the villus, cytotrophoblast, and stromal cells of a complete hydrated mole without the maternal genome. In contrast, partial non-molar abnormal gestational maternal genome has strong nuclear p57 positive, which can be used to exclude complete mole. However, p57 cannot differentiate between partial hydrated mole from non-molar gestation. The cytogenetic of complete hydrated bacillary hydrophobic spontaneous abortion are different. Typically, complete hydrated mode is diploid, that is 46 XS chromosome with both X chromosomes from paternal origin, whereas partial hydrated mode triploid with maternal paternal genetic origin. Hydrophobic spontaneous abortion normally is 46 XS both parent. Microsatellite short tandem repeats genotype enable the precise diagnosis of complete hydrated mole and facilitated by identifying the absence of maternal genetic contribution and diandric triploid respectively. Microsatellite short tandem repeat genotype enabled. Rarely invasive STD moles can be diagnosed by hysterectomy or biopsy monitoring. Choriocarcinoma grossly tumor is bulky, hemorrhagic, necrotic area. Apart from the uterus, it can be found in tubes, ovary, lung, liver, spleen, kidney, bowel, and brain. Histologically, choriocarcinoma, so absence of chorionic villi. Choriocarcinoma, absence of chorionic villi, abnormal intermediate presence of abnormal intermediate trophoblast and cytotrophoblast, rimmed with syncytial trophoblasts with areas of necrosis and hemorrhage. Genotyping analysis can be identify unique parental allele, confirm the choriocarcinoma, germ cell origin, or somatic carcinoma or trophoblastic. Placental side trophoblastic tumor. Grossly PSTT appear as white to tan yellow nodules masses varying from 1 to 2 cm. Average is 5 cm of endomyometrium with half of the gases invading deep into the myometrium. Histologically, this is mononuclear intermediate trophoblast on the maternal side of the placental bed. Tumor cell irregular nuclear membrane, hyperchromatic nuclei, dense eosinophilic to ammophilic cytoplasm. Post tumor has low mitotic count. Chorionic villi usually absent. Tumor cell diffusely express human placental lactosine and MUC4 and HSD3B1, HLA-G, MLCAM, CD146. Expression of HCG in inhibin is focal. Proliferation index generally increase with Ki67 expresses 10 to 30% of cells higher than that of benign excreted placental site reaction. PSTT so rare genetic imbalance. Epithelial trophoblastic tumor. Grossly tumor appear white to turn brown, discrete nodules with cystic hemorrhage masses invading deep into the surrounding tissue. Nearly half rise arise in the cervix or lower segment of the uterus and some in the fundus or broad ligament. Histologically, chorionic type intermediate trophoblast island relatively uniform intermediate trophoblast cells with moderate amount of eosinophilic or clear cytoplasm around nuclei. Surrounding extended necrosis associated with the hyaline matrix. Extensive geographic necrosis often present. ETT may coexist with trophoblastic neoplasm. Ki67 proliferation index is greater than 110%. ETD may mimic choriocarcinoma, especially after chemotherapy, PSCT, and squamous cell carcinoma of the cervix. The clinical presentation: molar pregnancy. Patient usually presents with second trimester bleeding, and as a diagnosis is often made in the first trimester with ultrasound examination. Complications: the hyperemesis gravidarum, preeclampsia, hypothyroidism less common. If there is less common. If there is vaginal passage of gestational product, basically may be seen. The typical honeycomb appearance of complete mode is rarely seen, especially in the first trimester. Typically, there is absence of fetal part, cystic appearance of placenta. Hence, molar pregnancy should be diagnosed on histological examination. Typically, in the absence of fetal part, cystic appearance of placenta, hence molar pregnancy should be diagnosed histologically after evacuation, spontaneous abortion of subsequent molar pregnancy. GTN, post-molar GTN is usually diagnosed by HCG surveillance without symptoms. As a Figo committee definition of post-molar GTN, HCG level change histology specific investigation. The HCG monitoring of GTN, HCG assay candidate, all from HCG include beta HCG, core HCG, C2 HCG, NIC-free, beta core, preferably hyperglycosylated, should be used when possible. Persistently low HCG level continuous monitoring as so may progress to GTN while rising HCG level. To exclude false positive test, another assay may be used. The Figo criteria diagnosis post-molar when the plateau or HCG last for measurement over a period of 3 weeks longer, that is day 1, 7, 40, 21. When there is a rise in HCG, when there is plateau of HCG, that is last for measurement that in over a period of 3 weeks, or when there is a rise in HCG in 3 consecutive weekly measurement over a last period of 2 weeks, that is 1, 7, 14. If there is histological diagnosis of choriocarcinoma. Gestational trophoblastic neoplasia after non-molar pregnancy, as only about 50% of GTN have molar pregnancy. The rest can occur after spontaneous abortion, ectopic pregnancy, and term pregnancy. Aside postpartum abnormal vaginal bleeding, other clinical presentation can include bleeding from the metastatic sites such as liver, spleen, intestine, lung, brain, pulmonary symptom, neurological symptoms from spine, brain metastasis. GTN should be considered in the differential diagnosis of patient with unusual presentation. HCG should be performed as part of the workup. The treatment, the suction evacuation and the curettage, ideally performed under ultrasound guidance, is the preferred method of evacuation of molar pregnancy. Independent of the uterine size of the maintenance fertility desire, it recommends that 12 to 14 mm suction cannula use. Intravenous oxytocin infusion may be started at the onset of suction curettage, may be continued for several hours post-operative to enhance uterine contractility, decrease blood loss. Because the risk of bleeding increases with uterine size, blood for transfusion should be available when the uterus is greater than 16 weeks. RH immunoglobulin should be given to RH negative women at the time of molar evacuation. As RSD factor expressed on the tropoplasm, judicious use of appropriate evacuation equipment technique, access blood product, carefully intraoperative monitoring, early recognition of cancer complication is improved. If there is no persistent bleeding, second evacuation is usually not needed. The tools for investigation, the chest X-ray appropriate to diagnose long metastasis can be used, counting the number of long metastasis to evaluate the risk score. Long CT may not be used in the risk score. Liver metastasis may be diagnosed with ultrasound or CT scanning. Brain metastasis may be diagnosed with MRI or CT scanning. Hysterectomy is an alternative to suction curettage if childbearing is completed. In addition to evacuate the molar pregnancy, hysterectomy provides permanent sterilization, decrease the need of subsequent chemotherapy by eliminating the risk of local myometrial invasion as a cause of persistent disease. Medical induction of labor hysterectomy are not recommended in molar evacuation, since these methods increase the maternal morbidity, development of post-molar GT and recurring chemotherapy. Prophylactic administration either methotrexate or actinomycin D at the time of immediately following molar evacuation is associated with the reduction in the incidence of post-molar GTN is 3 to 8%. However, it should be limited to special situations in which the risk of post-molar GTN is much greater than the normal, where adequate HCC follow-up is not possible. Follow-up HCC monitoring every 1 to 2 weeks is essential for early diagnosis management of post-molar GTN. On the other hand, post-molar GTN rarely occur after the spontaneous return of the HCC level, allowing the certain follow-up period for most. Hence, single additional confirmed normal HCC measurement 1 month after first HCC normalization recommended for partial hydrated mole. Monthly HCC measurement should be obtained for only 6 months after HCC normalization for complete mole. Single additional confirmed normal HCC measurement 1 month after HCC normalization recommended partially, for monthly for 6 months incomplete. After additional confirmed normal HCC measurement 1 month after first normalization is recommended for partial. Monthly HCC measurement should be obtained only for 6 months after its normalization. Termination of pregnancy not indicated if accidental pregnancy occurred during surveillance after the HCC level has returned to normal. Indirect data so not indicated. Safe to recommended oral contraceptive. The risk of recurrence in later pregnancy is low, that is 0.6 to 2% after 1 molar pregnancy, although much increase at conjugative pregnancy. The mutation in NLRP7 and KSDC3L have been reported in the recurrent molar pregnancy. The coexistence of normal pregnancy with molar pregnancy rarely coexists with normal pregnancy. The diagnosis is usually made on ultrasound, although there is high risk of spontaneous abortion, 40 to 60% as well live birth. The risk of GTN coexisting molar normal pregnancy compared with singleton pregnancy increased from 15 to 20% to 27 to 46%. Molar normal pregnancy. In the absence of complication, normal genetic ultrasound finding, pregnancy can proceed. Gestational tropology, the treatment of GTN is generally by chemotherapy. The base regimen depends on the stage and classification. 2000 Figo staging and classification. A risk score of 6 below is classified as low risk and more than 6 is considered high risk. Patient with low risk GTN should be treated with one of the single agent methotrexate actinomycin D protocol, listed box 3. The Cochrane review 2016 67 randomized control show that actinomycin probably more likely to achieve primary cure than methotrexate. The first line method is probably more likely to fail than actinomycin D treatment. Chemotherapy should be changed an alternative agent if there has been good response to the first line agent, but the HCC level plateau or rise during treatment, or if toxicity preclude an adequate dose or frequency treatment. Studies show that change to single agent activity from a single agent method gives a good response rate between 76 to 87% in relatively low HCC level. Chance of curative treatment is strongly related to HCC level at the time when single agent actinomycin start, as there is continuous update of the cutoff level based on the evolving data. Physicians should refer to local guidelines from time to time. The complete response rare avelumab second line treatment for methotrexate failed low risk patient avelumab. Low risk patient only 53 patient. Disappointingly lower than the second line actinomycin chemotherapy is not recommended as a standard salvage treatment in low risk case. Response rate for available. High risk score 5 to 6 clearly the diagnosis correction of both estrogen increase risk of resistance. The gestational trophoblastic tumor strictly limited the uterine corpus, extending to the adnexa or the vagina, but limited the genital structure. Trophoblastic tumor extending to the lungs with or without genital tract involvement. Extending to the adnexa or to the vagina, but limited to the genital structure. The gestational trophoblastic tumor strictly confined to the uterine corpus, extending to the adnexa or to the vagina, but limited to the genital structure. Lungs without genital tract and all other metastatic stage. The Figo scoring system. The age is 0, 1, 2 for scoring. Age is less than 40 is 0, more than 40 is 1. Antecedent pregnancy, if mole is 0, if abortion is 1, if sperm pregnancy it is 2. Interval from index pregnancy month, if less than 4 months is 0, 4 to 6 months is 1, 7 to 12 months is 2, more than 12 months is 4. Pre-treatment SHG level, if it is less than 1000, that is 0, 1000 to 10,000, 1, 10,000 to 1 lakh is 3, a 2, more than 1 lakh 4. Largest tumor size including uterus, if 3 to 4 centimeter is 1, more than 5 centimeter is 2. Site of metastasis, number of site lungs is 0, spleen and kidney is 1, gastrointestinal tract is 2, brain and liver is 4. Number of metastasis 1 to 4 is 1, 5 to 8 is 2, more than 8 is 4. Previous failed chemotherapy, if single drug is 1, if single drug is 2, 2 or more drug is 4. 2 stage and allowed risk factor score as patient's diagnosis allocated to a stage as presented by Roman numeral 1, 2, 3, 4. Separate column from the sum of all the actual is better score expression Arabic numeral stage 2, 4, stage 4, 9. Box for first line agent chemotherapy regimen, low risk gestational trophoblastic methotrexate 8-day regimen, 50 mg methotrexate intramuscularly on day 1, 3, 5, 7 with folinic acid 50 mg orally, 24 hours after methotrexate, day 2, day 4, 6 and 8. Repeat every 2 weeks. Methotrexate 0.4 mg per kg intravenously or intramuscularly for 5 days every 2 weeks. 8-day regimen. Actinomycin D plus 1 pulse 1.25 mg per meter square every 2 weeks. 0.5 mg interval for 5 days every 2 weeks. Other methotrexate 30 to 50 intramuscular weekly. Methotrexate 300 mg infusion every 2 weeks. Imaco regimen. Day regimen 1, day 1 etoposide actinomycin imaco. Methotrexate D. Day 1 100 mg per meter infusion over 30 minutes. 0.5 mg intravenous bolus 100 mg intravenous bolus. Etoposide actinomycin polinic acid. Regimen 2. Lowering the threshold, the use of multi-agent chemotherapy in the authorized low-risk patient. In low-risk disease, although hysterectomy is an option for select patients who have fulfilled their child wish, post-operative chemotherapy will still be needed as well as HCC similar to patient managed exclusively with chemotherapy. As a result, hysterectomy is not highly recommended. After HCC level has returned to normal, 2 to 3 more cycles of chemotherapy will decrease the chances of recurrence. Overall complete remission rate is 100%. High-risk gestational trophoblastic multiple agent chemotherapy regimen used to treat high-risk GTN. Most commonly used imaco regimen. Etoposide, methotrexate, actinomycin D, cyclophosphamide, vincristine. Although the Cochrane database revealed failed to conclude what combination was best, about 20% patients don't undergo complete response to immunotherapy, but most can be salvaged for other therapy. The overall survivability of patients with high-risk GTN are now running at 95%. A number of adverse features that predict poor outcome include liver, brain metastasis. And the management is such patient together with salvage therapy discussed below. Ultra high risk trophoblastic neoplasia and salvage. Among the high risk group is defined by Figo staging classification subgroup score. With more than 13 getter patient is liver, brain metastasis do poorly treated with first line multiple agent therapy. Similar findings have been reported by the others. For those with massive disease, starting with standard chemotherapy may cause sudden tumor collapse with severe bleeding, metabolic acidosis, myelosuppression, septicemia, multiple organ failure, any or all of which gradually elided. To avoid the use of initial gentle rather than full dose chemotherapy seems logical. To avoid this, the use of initial gentle rather than full dose chemotherapy seems logical. Indeed, induction toposide 100 mg plus cisplatin 20 mg per meter square on day 1, day 2. Repeat weekly for 1 to 3 weeks before starting the normal chemotherapy. Appears to have eliminated earlier death in one series, with promising result now reported by the authors. For those patients with liver metastasis, without brain metastasis, very high risk score, etoposide, platinum, IMA or another more intensive chemotherapy regimen, EP or IMA rather than IMACO. For those patients with liver metastasis, either without brain metastasis or very high risk score, etoposide and platinum or etoposide, methotrexate, actinomycin or another more intensive therapy, box 4 rather than IMACO may yield better response and outcome. For such high risk patients, longer consultation with 4 cycles chemotherapy should be considered. In patients with brain metastasis, increase in the methotrexate infusion 1 mg per meter square will help draw across the blood-brain barrier. And intrathecal methotrexate 12.5 mg may be used in some cases. This can be given at the time of when IMACO is used with the etoposide. Some center may give whole brain radiotherapy 3000 centigrade in 200 centigrade daily fraction concurrent with chemotherapy. Use stereotactic gamma knife radiation to treating existing residual brain metastasis after chemotherapy. Patient with resistant IMACO mostly salvage with paclitaxel, etoposide alternative with paclitaxel, cisplatin. In China, 5 uracil based 5 regimen also effective salvage treatment. When there is resistant EP, IMA or TE, TP, options include the number of other standard high dose chemotherapy regimen, autologous peripheral stems with autologous stem cell support. Recent work such as the checkpoint immunotherapy such as pembrolizumab also have been spared them with toxicity, high dose therapy. Surgical surgery should not be overlooked. Role of surgery. Surgery have an important role in management of GTN. Hysterectomy can be considered uncontrolled uterine bleeding, although it can often be avoided with the use of uterine embolization. Minimally invasive is open abdominal hysterectomy. Patient with GTD appear to have comparable oncology outcome with less blood loss. Certain hospitals. Laparotomy may be needed to stop bleeding. Organs such as liver, gastrointestinal, kidney, spleen. Neurosurgery needed if the bleeding is brain increase in internal episode. The resection isolated resistant tumor may also continue. Radiotherapy has limited role in GT except in treatment of brain metastasis, although its efficacy compared with the intrathecal methotrexate is controversial. The salvage therapy, both PSTT and ETT are less chemosensitive choriocarcinoma. PSTT and ETT less chemosensitivity choriocarcinoma. Hysterectomy is the primary mode of treatment in most cases. Surgery also plays an important role in metastatic disease such as resection of solitary organ metastasis. If fertility feature is desired, especially localized lesion, conservative management such as uterine curettage, cystoscopy, resection, chemotherapy must consider. Fertility is not suitable in different lesion. In advanced stage, EPMR consider interval antecedent pregnancy more than 48 months. Stage 4 disease affect the most significant adverse prognostic factor. Additional experimental therapy. After treatment of GTN, follow-up SCG monitoring every month for at least 12 months. Essential surveillance of relapse. Reliable contraception must be used throughout this period. Future fertility, pregnancy, offspring not affected, although psychosocial sexual counseling needed some patient. Establishment of a GTT center. The salvage therapy, the etoposide, cisplatin, etoposide, methotrexate, actinomycin, and TP, TE, paclitaxel, cisplatin, paclitaxel, etoposide, methotrexate, bleomycin, etoposide, BIP therapy, etoposide, ifosfamide, and cisplatin, ICE therapy, carboplatin, BP, bleomycin, etoposide, cisplatin, 5-fluorouracil, actinomycin, fluoroxetine, actinomycin, high dose chemotherapy with autologous bone marrow or stem cell transplant, immunotherapy with pembrolizumab.